not so. Okay, so today I just called the talk designing, analysing and writing up your project. I mean, there's so much more that could be said about how to do a research project, and that's why I sent around that paper, which is if you look on the email I sent around as the invitation to this particular meeting, there's a paper called How to Write a Minor Thesis, and that is probably it's a summary of what you need to do in writing up your project. We don't have that much time today to talk to all of the points in that particular paper, but I hope if you have time to read it, it might make sense to you. All right, so there's quite a bit of feedback. I wonder if people can you please mute your devices? Yeah. Now, I want to go back to the way you do a project. Like I come up with a project and start a project and then complete it. And usually a project starts with an idea or a problem. And I'd encourage anyone who hasn't yet started a project to come up with a topic that is something of interest to them, is an idea that they have seen in clinical practice and want to explore more about that. So most people can come up with an idea. What's the biggest challenge is converting an idea into a clear, answerable research question. And that's the second stage, is to convert your idea into a clear and answerable research question. I won't go through all of these steps, and some of them are not necessary for people who are doing like relatively small research projects. Most of our projects don't require funding. You don't always have to be engaging other people. It's something that largely you can do, maybe with your nursing staff and others. But most of these, somewhere along the line in your project, most of these steps will be important. So I won't read them out now, but as we go through this talk about how to do a project and write up a thesis, hopefully that will become clear. Something that I hope you all know how to do already, but maybe you don't, maybe no one's taught you how to search the literature. And often people who are starting to do projects, they want to know how to find other papers that are similar to the studies that they are doing. And I hope that you know how to use Pubmed, but if not, I thought I would show you how to use Pubmed very simply. Now, I think if I click on this, I'm not sure that you'll be able to see Pubmed, but please tell me. I'm going to click on this and try to get into Pubmed. This is Pubmed. Can you see Pubmed now?
No.
That's okay. I'm just gonna now can you see it?
Yes.
Yeah, okay. So I know I might be telling you things you already know, but let's just go through what Pubmed is. Now, Pubmed is it's a search engine. We're all used to search engines, Google and other things, but Pubmed is a medical health information search engine, and it's very good, and it's free, and it's available anywhere. And so I use two search engines for looking for literature, articles, journal articles. I use Pubmed, and the other one I use is Google. But I use not just any Google. I use a version of Google called Google Scholar, and both of those are free. And there are some search engines for journal articles that are not free. You have to pay for them. I never use them, but Pubmed is probably the best one. And if I'm not mistaken, there's 30 million articles in Pubmed. And of course, we could never look for all of those or worry about all of those. But Pubmed helps you find the articles you want. So I'm going to I'll just admit some people as we go. I'm going to let's see, put in some phrases, some search terms, and we'll see if we can find some articles. What would you like to search on? What's a question that you have? I see Dr. Tina, you're wrong there. And perhaps it would be good to search for some articles related to Tina's study. So, for example, if I was searching for some articles related to Tina's study, I'd probably put in HIV and, let's see, perception, family, often when you're doing a search, you just need to include some keywords and see if you come up with anything, and then you may or may not. I'm going to put in Papua New Guinea because it's about the perception of families and people living with HIV in Papua New Guinea, and I might put in adherence, perhaps. I've spelt that right, and then you can press search. Now there's several ways you can search. One, oops, I'm not connected. Why is that? I'm going to stop sharing and go back to that. Sorry, that didn't work. I got unconnected. Let's see. I must have got disconnected. I'll just go in again. Okay. Now, I'm going to share my screen again. Okay, we'll try again. Yeah. Find any articles on that. So I'm just going to take out those. You'll just see. Okay, so in the search terms I originally put in, there was no articles that had all those search terms. So then you can reduce your search term number to something else. And what you can see is there's 12 articles that have looked at it's something to do with the perception of HIV among people with HIV in Papua New Guinea. And you can read the articles and see what you think is relevant to your studies. There are other ways you can search Pubmed, and some of them are a little bit more advanced. So I'll just show you a slightly more advanced way to do it. You could put the same search terms in, HIV and perception. You search that, and then you can, and then you can add in, let's see, you can add in other search terms, like you might want to add only papers that were published this year. So 2021. One to now, and we might just add that, and then all fields. Okay, and I might want to search papers that have just published on, whoops, that didn't retrieve any papers, so we might go back. So you found those 12 articles again. Now, I won't go through this in much more detail, but it's just like, I'm sure you can use PubMed just like you search things on Google, but it's much more appropriate to search using Pubmed. Pubmed has now, in the last 10 years, Pubmed's made most of the articles free access. So it used to be that all you got was as an abstract or the title of the article, but now mostly they're free articles. So you can click on that article. Let's see, we'll click on this article, and there it is. It's free, and you can open up the full text of the article to read it. All right. So I'm going to stop sharing, and now. Has anyone got any questions about searching articles? We can talk about that a bit later, but I want you to be able to search for articles related to the topics that you're looking at. That was a very, very brief run through Pubmed, but we can do more on that later if you like. Once you've got a paper, I think it's useful to think about how you actually read a paper. And we don't have time to read all the papers that we identify, but I try not to read the entire paper. I try to scan a paper to see if I think it's relevant to the topic I'm wanting to research or to find out information about. It's useful to know what the structure of a paper is and how it's what parts you should really focus on. I try to focus on the parts of a journal article that are the most objective. There are some parts that are objective and some parts that are somewhat subjective. That is, it's like the author's opinion. But I try to focus on the parts that are most objective. So that there's the title and the abstract. That should be very objective. And when I'm looking at the paper, I want to know whether it's relevant. Is it relevant to me, yes or no? If it's not relevant to me or the topic that I'm thinking of at the time, then I just don't read it. But if it is relevant, then I go on and read more. The introduction is usually, sometimes it can be long and sometimes it can be short, but what you should be able to find in the introduction is to find out why the author wrote the paper. Why did they do this study? And so in the introduction, you should say, if you're writing a paper, you should say why I did it. All right, there's a lot of, an introduction doesn't have to be a literature review. It usually has some reference articles in it, but it doesn't have to be an exhaustive literature review. It's much more important that you just say why you did the study. That is, it's somewhat subjective. So I usually don't spend too much time on the introduction. The methods is the most important part of the paper in a way, in that the methods is, it's designed to say how you did it, right? And so if an author has written the methods properly, then that should enable anybody else to take that method and reproduce the study in another environment and see if they come up with a similar result. And so the method should be written in a way that helps other scientists or other clinicians, other researchers to know exactly how you did it. So that's what the method should be, how I did it. And then the results should be what I found. That's all you put in the results, the objective findings, all right? And so both the methods and the results is very objective. And then the discussion, that's what it means, and that's subjective. Often that is, it's what your results mean in the broader context of other research that's been done, in the context of health in general, or in that particular topic. You compare literature from compare studies from other places and see if they compare to your study. And you include in that recommendations and things. It's still subjective. Sometimes people think the discussion is just a repeat of the results. It's not that at all. You shouldn't, in your discussion, you shouldn't repeat your results. You should interpret your results and say what you think they mean. But inherently that's subjective. So when I'm reading a paper, I tend to focus most on the title and the abstract, the method and the results. Then the conclusion is highly subjective. It's what the author thinks the study means. So if you focus on those three parts, then you get the most out of a paper, really. Of course, if it's a really important paper, I read the entire thing, but the main thing is to focus on the objective parts. And when I'm looking at the methods and the results, I'm looking for really whether or not it's been written in a way that's of good quality, and it's using a valid methodology, and the results are valid. So they're the things that I want to know. Okay, I was going to talk a bit about basic epidemiology, because most of the studies that we do are epidemiological in some way. They're mostly it's just basic descriptive epidemiology. And I think what we've got to be really good at is descriptive epidemiology. There's lots of other types of epidemiology, analytical epidemiology, but mostly it's just descriptive, basic, simple description. I'll talk a bit about types of studies, but I want you to have a good understanding of what the basic descriptive statistics are. So means and medians, incidence and prevalence, not so much odds ratios or relative risk. They're a bit more analytical. But for most of the studies we're doing, they're means and medians, proportions, rates and ratios, incidence and prevalence. Epidemiology actually means that around the study of people. That's all it means. It's from the Greek word, around the study of people. And some of you might have heard me say this before, but there's lots of, as I say, there's lots of different types of epidemiology, and we should focus most of what we do is clinical epidemiology, and most of it is descriptive. That is describing disease by time and place and person, and measuring in some way the burden of disease or yeah, that sort of thing. Occasionally we do analytical epidemiology, which looks for whether or not there's risk factors or associations between certain treatments and their outcome, or exposures and their outcome, or looking for links between comorbidities and outcomes. But that's becomes more complex. So, which is fine, but that involves looking at odds ratios and relative risks. And then there's interventional epidemiology, which occasionally, you know, we've done registrars projects looking at interventional things like controlled trials and that sort of thing. But you've got to start with understanding descriptive epidemiology most importantly. Okay, this is a very good example of descriptive epidemiology. Some of you might have heard me talk about this before, but even before there was the word epidemiology, there was the first epidemiological study was this, and this is a map by a man called John Snow, who was a physician in London in the 1800s, in the 19th century, and there was a big cholera outbreak where many people were dying of cholera, and John Snow was a physician, and he mapped, just drawing this map. This is his map, and he mapped the where people came from who died of cholera. And what was striking is that the deaths were not evenly distributed, and the deaths were heavily concentrated around this street. Most of the people who died were from this street. And so what it tells you, one thing, that diseases are not evenly distributed. This is fundamentally important to everything we think about. Tuberculosis isn't evenly distributed, HIV is not evenly distributed, cholera in PNG is not evenly distributed, COVID is not evenly distributed. All of those diseases are unevenly distributed, and a lot of epidemiology is trying to understand why they're distributed the way they are. And what John Snow found was that the risk of death from cholera was 5 times as high if you lived in this place called Broad Street than if you lived elsewhere in London. And he identified, even before we knew that cholera was due to bacteria, he identified that there was a broken sewage pipe close to the water pump that was in that street, in Broad Street. And people drank from the sewage pipe, and therefore they got cholera. And as I say, we didn't know at that stage that there were bacteria as a source of cholera, but by doing basic descriptive epidemiology, by mapping a disease outbreak, he was able to identify what the source was, but using very practical terms. And it's famous now, but he was able to stop the deaths from cholera by simply disabling this pump, so people didn't drink from that pump and they got their water source from somewhere else. Okay, as I say, I want to try to explain what rates and ratios and proportions are, what incidence and prevalence is, and maybe means and interquartile ranges and confidence intervals. I won't have time to cover all of that today, but I want to first of all give some discuss basic epidemiology, and then I'm going to talk a bit more about how to do projects and some pitfalls that I've seen. So when we think of descriptive epidemiology, we need to think about it in terms of proportions, rates, and ratios, okay? And a proportion is simply like a percentage or a fraction. It's a numerator over a denominator. So we could say, what's the proportion of children in your ward with pneumonia? And that will be, the numerator will be the children with the number of children with pneumonia in your ward divided by all the children with pneumonia in your ward. And that proportion of children with pneumonia would be a prevalence of pneumonia at a given point in time. That would be the prevalence of pneumonia. I'll explain what prevalence is later, but it's a proportion, okay? And but you could also say, well, what's the proportion of children with pneumonia who have severe pneumonia? And in that case, the numerator would be those that with severe pneumonia divided by all the children with pneumonia. All right, it's a different fraction, a different proportion. All right, and so we need to really understand what proportions are, and then there's the term called a rate. All right, a rate is again a proportion. A rate usually has a time dimension. Okay, so if you think about like the infant mortality rate, I'm sure you all know this. The infant mortality rate is the number of children who die up to the age of 12 months divided by 1,000 live births. Okay, that's the infant mortality rate. Or the neonatal mortality rate is the number of babies that die up to the age of 28 days or 1 month of life divided by every 1,000 live births. All right, the child mortality rate is the number of children who die up to the age of 5 years divided by every 1,000 live births. All right, and so a rate has a numerator and a denominator. Now, a ratio is a little bit different. It's one number divided by another number, but the bottom number, the denominator, doesn't have to be the same as the top number. And so the maternal mortality ratio, for example, this is a bit confusing, but the maternal mortality ratio is the number of mothers or women who die in pregnancy or labor or the immediate postpartum period divided by 100,000 live births. And the reason why it's called a ratio is because the numerator, which is mothers, is different to the denominator, which is babies or births. It's just a convention as to how that's calculated, and it's called a ratio because the numerator is different to the denominator. But a rate, the numerator is the same as the denominator. You don't need to be too understand that in too much detail, but just to know that a rate and a ratio are similar, but they're slightly different. And a proportion is like a fraction. Okay. There are lots of different measures of a disease burden, and most of these are rates. Okay, so the child mortality rate, the infant mortality rate, as I said, who knows what the perinatal mortality rate is? What's the perinatal mortality rate? The perinatal mortality rate's a little bit like the neonatal mortality rate, but it's a bit different because the neonatal mortality rate doesn't include stillbirths, whereas the perinatal mortality rate includes stillbirths and babies that die in the first 7 days of life. All right, so it doesn't include the whole of the neonatal period, but it includes stillbirths plus deaths in the first 7 days of life divided by every 1,000 live births. All right, and so they're just conventional definitions, and it's useful. I think at least we need to know about the child mortality rate, the infant mortality rate, the neonatal mortality rate, and the perinatal mortality rate. The stillbirth rate, the problem with the neonatal mortality rate is that it doesn't include stillbirths, and stillbirths are quite a proportion, quite a large number of babies that die. And so that's why the perinatal mortality rate is also important. And then, as I said, the maternal mortality ratio. Often in our hospitals, we're not looking at these rates. We're looking more at case fatality rates, which I'll just explain that. That's a bit of an easier concept to grasp. But the case fatality rate is, let's say you want to look at the case fatality rate for diarrhea in your ward, where the numerator would be the number of children who die from diarrhea, and the denominator would be the number of children with diarrhea. So it's a case fatality rate, right? Sometimes people would look at the case fatality rate overall, the overall ward mortality rate or case fatality rate, and that would be the number of children who get admitted to the ward who die divided by the number of children who are admitted to the ward. That's the case fatality rate. And in PNG at the moment, our case fatality rate overall is around about 5%. So that means you can turn that around and say, well, that means the survival rate is about 95%, which is pretty good. Okay, it's just a proportion, and you can see proportion one way, or you can see it the other way. Now, if anyone's got any questions about rates and ratios and proportions, please ask. I want to try to describe what prevalence and incidence means. And I think I won't go through all of this, but I think I'll send the slides around, but I think a good way of trying to understand prevalence and incidence is really try to understand through the prism of a couple of diseases, all right? And so I think if we understand the difference between prevalence and incidence, it's helpful to understand it in context with different diseases. I won't talk about these other ones, but incidence and prevalence I want you to understand well, all right? There's some other useful rates that we look at, like treatment completion rates or adherence rates. You know, what's the rate of adherence to children who are on TB medications or antiretroviral therapy? We can look at those adherence rates. And sometimes we look at things like event-free rates. So the seizure-free rate in children with epilepsy, or the number of years that a child who has leukemia is free of disease. These are rates that can become quite important. We can also look at other things that are not medical. So literacy rates in a population, that's the number of children who can read, for example, divided by the number of children in the population, or sometimes it's a young adult literacy rate. All of these things are simply rates that are often used in epidemiological studies. But I wanted to focus a little bit more on incidence and prevalence, so you have a bit of an understanding of what they are, because often we get them confused, I think. And the prevalence is I'll give some examples and it's easy to understand, but the prevalence is the number of people with the disease or the outcome at a given time. It's like if you do a cross-section of the prevalence of malnutrition in your ward is the number of children with malnutrition in your ward today divided by the number of children in your ward. And it's really a proportion, it's the prevalence of. And similarly, if you were to look at, say, the prevalence of diabetes in your community, you'd look at the number of people who had diabetes in the community divided by the number of people in the community. So it's a cross-sectional view of the frequency of the disease in your community at a given point in time. The incidence is a little bit different, because the incidence is the number of new cases of the disease over a specified period of time. And so often we'll talk about the incidence of a new disease, for example, and that's let's say the incidence of COVID in the community is the number of cases of COVID divided by over a given period of time, divided by the population in that community over that period of time. That's a bit different to the prevalence of COVID, which is just looking at the community at a given point in time in cross-section. I'll explain maybe a bit more about that. When you've got a chronic disease like diabetes, for example, diabetes it's relatively uncommon to have new diagnosis of diabetes, but if you look in a population, there might be quite a bit of diabetes there, and that's because it's a chronic disease. People have, if you've got a disease that has a high attack rate, if you like influenza, then you should be looking at the incidence of influenza, the number of people who get a number of new cases of influenza. But for chronic diseases like diabetes, it's best to look at the prevalence of diabetes in the community, because that tells you how many people are living with diabetes in your community. You can also look at the number of new cases, that's the incidence, but they're just a bit different. Okay. So I think rheumatic heart disease is a good example of incidence or prevalence. And often we think about the incidence or prevalence of acute rheumatic fever or rheumatic heart disease. If I was wanting to describe acute rheumatic fever frequency, what would I use? Would I use prevalence or incidence? What do you think? Well, children with acute rheumatic fever, they come into your hospital, they have a fever, they have joint pains, and they are sick for 2 or 3 weeks, and then they hopefully get better, and then they go home. They've had an episode of acute rheumatic fever. So it's an acute illness, isn't it? Acute infection for which it's more appropriate to talk about the incidence, right? Whereas some of those children with acute rheumatic fever, they go on to have damaged heart valves, and so therefore it's more appropriate to talk about the prevalence, because they may have rheumatic heart disease in the community for many years. And people have looked at this for example, in Fiji, they have done prevalence studies of rheumatic heart disease by doing echocardiography of children in schools, and found that the prevalence of rheumatic heart disease based on abnormalities of their mitral valve or their aortic valve are relatively common. It's not uncommon to see children who've got damaged valves from rheumatic heart disease, and that's looking at the prevalence of rheumatic heart disease, whereas the incidence is something that you can best understand by looking at hospital-based data of the number of new cases of acute rheumatic fever. I hope that sort of makes sense. I sometimes give this example of the difference between incidence and prevalence with tuberculosis, and I think it's this is quite important in regard to TB, because we often think we know how much TB is in the community by the number of cases that come to our health facility. But if you're looking at the number of new cases of TB that come to your health facility, that's looking at the incidence of TB, isn't it? It's the number of new cases. But that doesn't give you a very good understanding of the prevalence of TB in the community. And the reason why it's just as important to understand the prevalence of TB in the community is, especially for TB, many people have to reach a certain level of illness before they present to hospital. And so when a person presents to hospital and it's a new case, therefore incidence, then often there'll be many more people who actually have TB in the community who haven't reached that stage where they're presenting yet. And many people present only when it's late or when they've transmitted TB to other people. And sometimes they don't present because of geographical or cultural or educational issues or inaccessibility to health facilities. And what that means is that often the prevalence is much higher than the incidence. The incidence is the new cases, and the prevalence is how much TB is in the community. So incidence of TB at health facilities, we measure it all the time, but it's not a very good measure of the population burden of disease, right? And I wanted to just try to illustrate that with this by describing this study that was done in a place called Etep in Morabie province a few years ago now. And this was an important study, I think, because these a couple of Lutheran doctors at Etep wanted to know it started with an observation, and the observation was that they were seeing a lot of people present with abdominal TB, with grossly distended abdomens, lots of ascites, strands and adhesions on evident ultrasound, and they tap the ascites, and they find that it's straw-coloured fluid, and it looked for very much like abdominal TB, and they treat many of these patients and they get better. And this was, they were seeing lots of abdominal TB in this place called ETEP among children and adolescents and adults particularly, and they wondered why that was. And there's two possibilities. One is that for some reason abdominal TB seems more common in ETEP, but a more likely possibility was that people who had other forms of TB weren't presenting. It's only when people got very sick and had severe abdominal distension that they would present. But people who had pulmonary TB, they didn't present because they thought that a cough, a cough was a relatively normal thing. So they didn't come to the district hospital. And so this study was designed to understand the community prevalence of TB, not the incidence of abdominal TB, but the community prevalence of TB. And it was also designed to know whether or not, if you go out to a community and try to find TB by doing active surveillance, will you find lots of cases? And so if you do, what's the cost? I haven't got time to go through all of this today because I want to get onto more about how to do research, but I think this study gives a very good understanding of the difference between incidence and prevalence, right? And this study was done in these villages in ETEP, and what the doctors did and the nurses involved from ETEP was that they went to the communities and they screened over 17,000 people, and they came up with 1,700. So 10% of the population had some symptoms of TB. And of all of those people, then they examined them, and then they did sputum smears on all the people that truly had symptoms of TB, so symptoms or signs of TB. And they did nearly 300 sputum smears in all these villages at the time. So it was a very simple method of just clinical screening and sputum smear testing. That's all they did. And the reason to do something so simple is because it's a method of screening, active population-based screening that actually could be done anywhere in the world, and even in remote places. And so this was the laboratory scientist who was able to do the Zeal-Nielsen staining just in the village. And this is what they found. I won't go through it in too much detail, but they found 98 people who had smear-positive pulmonary TB, 17 children with TB, and 15 with extrapulmonary TB. So all up 130 people who had TB. So that's a lot of people that previously didn't know that they had TB. Their source population was 1,700 people. So we have to ask ourselves, well, what is the prevalence of TB in that community? Remember, prevalence is a percentage within the population at a given point in time. And so that usually when we talk about the prevalence of TB, we normally talk about it in terms of TB cases per 100,000 population. Right. And so this study, they looked at 130 people out of 17,000 people, and you can work out therefore what the prevalence is, 0.76%. So not quite 1% of people, but the prevalence was per 100,000 was 765. So 130 divided by 17,000 times 100,000, that gives you a prevalence per 100,000, and it's 765. And that's before this study was done, people didn't really have a good understanding of what the prevalence of TB was in communities. And you might say, well, that's fairly low for 100,000 people, but any community that has a prevalence of active TB, as smear positive TB, of anything close to 1%, that's a very high prevalence. And before we did this study, people said, oh yes, you can do that, but it's much too costly to do it. And And so we wanted to know just how much this would cost to do this type of study, this type of active community-based screening. And it cost overall 56,900 kina. And you might think, well, that's a lot of money. But in fact, if you look at the number of cases that were identified, so there were 130 cases identified, that comes out at 438 kina per case identified. So all up, that's not a very large amount of money per case identified to identify a case that people didn't know had smear positive TB and put them on to TB treatment. And so this type of study, it's trying to answer a very simple question. What's the prevalence of TB in a community? You can see how that you can go and answer such a study. All right, so there's several sorts of prevalence. I hope I'm not going too fast for you, but there's several sorts of prevalence, and it depends in some ways on the way you ask the question. All right, and so for example, if you ask the question, you can describe prevalence in lots of different ways. It could be point prevalence or period prevalence or lifetime cumulative prevalence. And so, but it depends on how you ask the question. So if you ask the question as, do you currently have asthma? Then that's, what do you think that is? Do you currently have asthma? What sort of prevalence is that?
Point prevalence.
Yeah, good, that's point prevalence, yeah. What about if you say, have you had asthma in the last 2 years?
Over a period.
Yes, that's over a period, isn't it? A defined period of time. So that's period prevalence. And then the question, have you ever had asthma?
A lifetime.
Yeah, lifetime cumulative prevalence, yeah. And this is important because the way you ask the question will determine the type of prevalence that you are testing. And the reason I say this is because if most of you know about the demographic and health surveys that are run usually about every 10 years, and that in the demographic and health surveys, they're some of our best information about incidence and prevalence. And in the demographic and health surveys, they ask a question to mothers, which is about the prevalence of pneumonia. And the question is this, that in the last 2 weeks, has your child had cough and difficult breathing? That's the question. And then there's another question that says, in the last 2 weeks, has your child had watery diarrhea? That's frequent watery diarrhea. And so what sort of prevalence are they asking in the demographic and health surveys?
Period.
Yeah, that's period prevalence, isn't it? It's over a period of 2 weeks. And there's a reason why that time frame is chosen. And it's a practical reason, really, because if you say asked, has your child ever had diarrhea, then almost all children will have had diarrhea at some stage. So mothers will always say yes. Or if you ask about, has your child had diarrhea in the last 12 months, over a longer period of time, then it's very hard for us as parents to remember how often or whether our child had an illness 8 or 10 months ago. But if you ask about it over the last 2 weeks, then of course we remember whether or not that occurred. And so there has to be some, my point is there has to be some planning around the way you ask questions when you do surveys like this. And they have to be asked in a way that is most likely to yield a valid answer, okay? So that's these prevalences, right? Okay, I want to talk now, so that's the first bit of the talk, but I wanted to talk a bit about, a bit more about mechanics of writing your reports and things. And so, as I said, most of us can come up with a research idea, but it's turning that idea into an objective question that can be answered with a research methodology is important. And you need to choose the method that would be appropriate to the question. And so, for example, in that TB study, we could have just studied the the people who were presenting with abdominal TB, but the real question is not so much about those people, but about the population as a whole. And so that's why the method had to be an active, it didn't have to be, but the better method was an active community-based survey, rather than just studying the people that were actually presenting with abdominal TB. You could do both, but one would look at the incidence of abdominal TB and the other would look at the prevalence of TB in the community. Both types of studies are valid, but you need to work out what's the most appropriate question to ask and what's the best method to use. After that, then your data collection form should reflect the questions that you've asked. And then after that, your spreadsheet should reflect your data collection form. And I'm going to go through in these in a little bit more detail, because many of you are up to this part of your research. Now, like I said, your spreadsheet, I find it quite useful to early on when you're doing research collecting data, make up your spreadsheet fairly early, because you want to know that the spreadsheet reflects your data collection form, and that your spreadsheet is analyzable. Okay, and so when I make up a data collection form, I want to make sure that each of the variables are objective and the metric is very clear. And then I make up the spreadsheet in the same way, so with the same order. So all the variables that are on the data collection form appear on the spreadsheet. And that way it's easy to enter data, because if you don't have them in the same order, then you can get the data entered in the wrong way. It's useful to think of there are probably more than three, but I think of about three types of variables. Either there are continuous variables, and there are binary variables, and there are categorical variables. So who can think of some continuous variables in a research project they might have been doing?
Age.
Age, yeah, age is a continuous variable. That's right, age. What else?
Weights as well.
Oh, I can't hear, but that's okay. I mean, things like age, weight, height, head circumference, mid-upper arm circumference, number of days of illness, number of days of cough. They're all continuous variables, aren't they? Because they're just a number, all right? And then you've got variables that are like binary variables, yes or no. So within a population, say, of children with malnutrition, then it's either the child's got, say, tuberculosis, yes or no, or the child's got is breastfed, yes or no. It could be like that. All right, that could be a binary variable. It could also be a categorical variable, because you might have, for example, some children that are breastfed, some children that are bottle fed, and some children that are on mixed feeding. All right, and so that becomes not a binary variable, not yes or no, but there's something in between. So it's a categorical variable. All right, and the reason I want you to think about the types of variables that you have on your spreadsheet is because continuous variables should always be written in the same way, and binary variables should be written in the same way too. So usually with your binary variables, that is yes or no, does the child have, let's say, in a population of children who've got diarrhea, do they have sunken eyes, yes or no? Lethargy, yes or no? Thirst, yes or no? It's usually a yes or no answer. And so your yes or no responses should be represented on your spreadsheet as 1 yes or 0 no, right? It's simple like that. Did the outcome could be measured as yes or no, like died, survived, so you'd measure the outcome as survived is 1, died is 0, for example. Yeah, they're just examples. Whereas continuous variables like weight, length, head circumference, mid-upper arm circumference, duration of illness, now they should be numerical. They should be a continuous numerical number. and they should be to a fixed number of appropriate decimal places. I'll explain about that in a minute. This is sort of important. Now, I wanted to give an example. Have a look at this spreadsheet, because I see many spreadsheets that are a little bit like this, that are made up like this. And the problem with it is that it's really not analyzable. And it's not analyzable for, I'll just point out many of the problems with this spreadsheet and how we can fix it up. All right. And some of the problems are, for example, let's look at just age. The child's age is, in this one, it's measured in days, 30 days. Secondly, this one is measured in 2 months. This one, it's 123 months. Is the one this is 1 week. All right. And so the metric that's used, metric is like the unit of measurement. The unit of measurement here is all different, isn't it? It's some it's days, some it's months, some it's weeks. And so that's the first error, is you have to have the same metric, right? So if you're looking at age, in this population, I'd scan through it and I'd think that most likely, most usefully, then the age could be measured in months. So for example, a child of 30 days, that should be 1, shouldn't it? For 2 months, it's just 2. 123 months, that's 123, fine. 22 days would be, if you look at 22 divided by 30, then 22 divided by 30, and that what you'd have is 0.7, all right, because that's 0.7 months, all right. And so instead of putting days, months, weeks, all you'd have is a single number, because you want to, it's a continuous variable that should just have a number, all right. Now here, this variable is not analyzable either, because there's a mixture of letters and numbers, all right. And so if you wanted to know, is this child a neonate, then it should be 1 if they're a neonate and 0 if they're not. You don't put no, all right. Similarly here, and in age, a computer will never understand a mixture of numbers and letters. So always just have it as numbers if you can. So this should be numbers. This should be numbers, 1s and 0s, because it's a binary outcome. And then with this one here, diagnosis, you can see there's lots of different diagnoses written in lots of different ways. So sepsis, malnutrition, and sometimes malnutrition is written as SAM, and sometimes it's written as SEV malnutrition. All right. And so it's impossible for a computer program to analyze this, all right, because even for descriptive epidemiology, you want to make it as uniform as possible. Let's look at weight. Here, again, there's an error because there's a mixture of numbers and letters, all right? And a computer will never be able to analyze that. Even Excel, you can't analyze that. All right. And so what you'd need to do is decide on a metric that made sense, because sometimes here the weight is recorded in grams, and sometimes here it's recorded in kilograms. And so you'd need to make sure that you're recording it either all in grams or all in kilograms. And in this circumstance, if you're recording in kilograms, you'd want to record to a uniform number of decimal places, right? It might be 2 decimal places, 2.80 kilograms or 2.90 kilograms or 3.5, here it would be 3.50 kilograms, etc. With this one here, you can't, there's a problem here because in some ways cough duration, again, you've got to define what the metric is. It should be in days. And so that should be 20 days. That should just be written as 7, not 7 days, because a computer will never understand a mixture of letters and numbers. And here, a question mark, a computer will never understand that. They never understand symbols either. So you can't put that sort of thing on your spreadsheet. In terms of outcome, then this person's listed several outcomes: survived, died, discharged. Sometimes is written discharged as DC, and sometimes it's written absconded. All right, and so there's at least 4 outcomes and sometimes 5. And it would be sensible in this circumstance to make it categorical. So survived, died. If you're interested in those that absconded, survived, died, absconded, that would be enough. Survived being discharged, I suppose, died or absconded might be the only three appropriate things. And then if you're particularly interested in studying people who died compared with those survived, then you can have another column that just had survived or died. So the point is to decide what the metric is and to have uniform metric all the way through. All right, with sex here, F, M, this, it sort of makes sense to us looking at it, but a computer will never be able to analyze that, because sometimes you've written M male as M, and sometimes you've written it as male, and sometimes you've written female as just F, and sometimes it's been written as female. And so a computer will never be able to analyze that. All right, so this is the spreadsheet when it was fixed up. And there's a number of things you can see. It's the same spreadsheet, but it's been fixed up so it is analyzable, okay? And so the age is in months, and like I said, we've put the age in different as fractions of months or whole numbers. If the patient is a neonate, then they get a 1. If they had pneumonia, so instead of having all of these different diagnoses jumbled up, then you have a separate column for each of them, and then you can, then it enables you to do simple counting. You can count the number of children that had pneumonia, or count the number of children that had malaria, count the number of children with HIV. You can look at the weight, the average weight, or the median weight in this population, or the average number of days of cough the child had, and you can look at the outcome as 1 or 0. Right? I'll just show you one other thing that this researcher, when he was entering his data on blood pressure, he put 90 on 30 or 85 on 42. And a computer program would never be able to understand that, because a program will never understand what a / means. And so if you were really wanting to look at this, then you'd need to have, one way would be to have systolic blood pressure in one column and diastolic blood pressure in the other column, all right, instead of having it written like this. All right? And so it's simply a way of how you can design a spreadsheet that's analyzable. Now, every year I see similar problems that people fall into, but sometimes I see very good spreadsheets, and I just wanted to show you a very good spreadsheet that I've seen recently. And this is Dr. Winnie Sadow's spreadsheet on her study, and I think it's excellent because it addresses all the points that I mentioned. So, for example, when she has recorded temperature, she's recorded it to 1 decimal place. When it looks like there's no decimal places here, but when you put in 40.0, then the Excel just defaults to 40 instead of 40.0. So she's recorded temperature to 1 decimal place. She's recorded the pulse rate, and she's said what the metric is. So beats per minute, and respiratory rate in beats per minute, SpO2 in percentage, right? Temperature in degrees Celsius. And these are binary variables. So was the child pallor or had edema or hepatomegaly? It's yes or no, you see, all the way through. Did the child have TB? Yes or no, etc. What was the outcome? 1 for survived, 0 for died. And you might say, well, here in this column, others, she's put hookworm, and that's okay, because that's a column where you just scan through and just look and see what the other diagnoses were, rather than having a separate column. So I think that it's possible to make up a spreadsheet that's easy to analyze, and I just use this as an example of an easy to analyze spreadsheet, and because I think we can all learn from this. All right. Okay, a few other pitfalls. One is, a lot of times I see people on their data collection form or in their spreadsheet, they're using like categories. So when I saw this recently, someone wrote the number of people in a household where they wrote less than 4 or 5 to 8 or more than 8. And that's fine in the final analysis. But when you do that, then when you record the number of people in a household is a continuous variable, isn't it? It's a continuous variable. So it should be, we should record it as a continuous variable. It's not recorded in certain categories. And the reason for that is that when you record it is in a category like less than 4 or greater than 8, then you lose information because you don't know whether less than 4 is 2 or 3, right? You don't know whether more than 8 is 9 or 12 or 20. It doesn't, what you're doing is losing useful information that if you just record it as a simple number, like I showed you in, say, this, let's see, in this spreadsheet, if you just record it as a continuous variable, like this duration of cough could have been less than 2, greater than 2, or less than 5, greater than 5, but you wouldn't then know that some children had cough for 20 days or 28 days. All right. So the point is, if you record continuous variables as categories, then you lose information. And the other thing is a computer can't understand these symbols, less than 4 or greater than 8. It doesn't understand those things. So you can't really analyze it if you record it that way. All right. Sometimes later on, when you're presenting your data in your thesis, then you can categorize the variables later, but not for data entry and analysis. Just record continuous variables as continuous variables. As I said, you should try to use the same metric of measurement consistently in a variable. Don't record age in months and years and some in days. So that means if you're recording in months, then 6 months, you just put 6. If it's 1 year and 8 months, that's 12 plus 8 is 20. You just put 20. If it's 5.5 years, that's 5 12s are 60 and 6 months. So the number's 66. If it's 2 weeks, then you put 0.5. If it's a newborn baby, that's just 1 divided by 30, which is 0.03. All right. So that's, if you had a column that was age in months and you had all those numbers, then you could calculate easily the median age. All right. But if you've got it with all this mixed up notation, then you can't do any calculations on it. So it's simple. When you're starting to write your project report, I encourage people to draw up these things called dummy tables, because it enables you to present your data even before you've analysed it. And most studies that have, most project reports have 2 or 3 tables, and they'll have a table of the demographics of the population you're studying, and then they'll have a table of results. And they might have 2 tables of results. And I wanted to give an example of what I thought was a very good study. And this is Dr. Michael Landy's study of malnutrition from a few years ago for his Master of Medicine. And this was, he made up some dummy tables to begin with. And this is his dummy table for patient demographics. And what in Dr. Landy's study, he did 3 surveys of, they were called point prevalence surveys. So he looked at the prevalence of malnutrition in the ward on 3 separate occasions, right? These were point prevalence surveys done over 2 days, right? And he looked at the prevalence of malnutrition, and he looked at the children with malnutrition, all right? And so when he made up his dummy table, these are the variables that he wanted to count. The total number of inpatients at the time in those 3 periods, the age. Now remember, age it's always important to define the metrics for your variables. So he defined this metric as being the median age in months, right? And then for the other metrics, mostly they're just numbers. So the number of people with extrapulmonary TB, the number of patients who also had diarrhea or pulmonary TB or lower respiratory tract infection, etc. So these were simply numbers, right? And so when he did the study, then when he finally finished the analysis, he was able to put these numbers in to his thesis, and then it made it a lot easier. And so if you when you're starting to write your thesis, try to make up these dummy tables that they have all the variables in, but they don't have any of the numbers. And then you can work out if there's any other things you need to add in the demographics tables or the results tables. In Dr. Landy's study, these were some of his results tables. He had 2 in his thesis, and these are his dummy tables for results. So he wanted to look at the average day when children started to be fed, the feeding volume that was given, the percentage of calories that the patients received, and the median weight gain in grams per kilogram per day. And so this is in the 3 surveys, 1, 2, 3. And he defined the metrics to start with. And then when he completed the data collection and entry and the analysis, he was then able to fill in these numbers. And these are the numbers when he filled them in. And so that's how I think it's useful to make up these dummy tables beforehand. All right. I'm not going to say too much more, but as I said, I sent around the paper on how to write a minor thesis, and it tells you it goes into more detail about how to do a basic research project and write a minor thesis. But mostly people's thesis structure will be a bit like this. It doesn't have to include all of these things, but a title page, usually a declaration, acknowledgements, maybe a table of contents, a list of the table of figures and diagrams, an abstract, the introduction. Remember I said that's why you did the study. Sometimes it'll have a literature review, then the methods, the results. These are the important parts, the results being important. Then a discussion and some conclusions, sometimes recommendations, and then a reference list, and then sometimes appendices. And I guess the point is that looks like a lot of information, but for most people who are doing a diploma of child health or a master's research project, you really only need to write somewhere between about 3,000 and 4,000 words. It can be more, of course, but you don't need to do very, very long theses. And I think sometimes it's better to write short theses that are a bit more like a journal article. And some of our best theses, I'm just trying to remember, some of the people have written very good theses that have just been about the size of a journal article. So maybe about 3,000 or 3,500 words. You can write more, of course, but sometimes it's best to just make your thesis relatively short and concise. Okay, so how to write a thesis? Well, you should start early. I know we're getting late, but you should start early. You should set aside time every week to do some work on your study and your thesis. It's not something you should put off for months or something and not do any work. Every week you should do something to it, and you should keep your supervisors informed and interested in your study and your thesis progress. I mean, sometimes your supervisors will be busy as well, and sometimes they might not seem interested, but you should keep telling them about your thesis so that they remain interested. I always like to have a single document, and often we write like a research proposal, and then we write another document for a thesis, and then we revise it and we write a third document. But try to have one document that you can use for your proposal to start with, and then you can revise that further and expand it to become your thesis. You should remember to back up all your data and all your writing. And as I said, you should write in the most concise way. Don't write. It doesn't have to be a very long thesis. Okay, so I'm just going to go back to that diagram I showed at the start. I won't describe it in detail, but if you're starting your Masters of Medicine research project, then probably your research will involve many or most of these different areas. So look, I have talked about a lot of things today in regard to research and your research projects, and I'm going to stop there and just see if anyone's got any questions.